We'll talk about those first. After that, Dr. Trowbridge is going to talk about some of the nuances of testing, and then Dr. Worth, if he's still able to join us, I apologize for the delay, will talk about the critical care perspective. Dr. Stockstill, Scourgely, and Hine hopefully have called in if we haven't lost them. So case number 1 I call Norm, and he came and showed up asking to get tested for corona. He's a 62-year-old with asplenia and obesity who had 6 days of lower respiratory tract symptoms, fevers, and myalgias. He traveled to Cancun, and he also attended a funeral which we know was a nidus for many of the infections in Portland. The rest of his history is there, as are his medications. On exam at the St. John Street Clinic, he had very mild hypoxia. He was drifty in the emergency department, and that resolved on its own, but he was noted to have sepsis, and eventually his COVID did result positive. Sorry, I'm just making sure. Bob, you got that? He was treated with a bolus, ceftriaxone, and was known to have some mild diarrhea on his first day. After about 2 days, his oxygen requirement somewhat rapidly increased, and he ultimately ended up in the ICU on hydroxychloroquine and azithromycin. The following day, he required intubation with lung protective settings, and he received a fluid-restricted resuscitation. He was on pressors for 4 days following that and received a single dose of tocilizumab. This is his chest x-ray during that time where his illness decompensated. You can see bilaterally he has interstitial infiltrates. It's kind of classic ARDS appearance. He had a very prolonged vent wean due to his encephalopathy. He needed a lot of diuresis. He ultimately extubated 10 days later and transferred to hospital medicine.
Yep.
He is...
Nobody can see the slides.
Oh, shoot.
It's on the phone.
People need to mute their.
I'm going to hang on pause. I'm just going to mute all callers. All right. Can everybody please mute their phones? Alright. And then I understand people cannot see the screen, is that true?
Text Ross with an answer.
Can someone communicate with Ross if you can see the screen right now?
No slides on my home screen.
You can go back to go to this screen to the bottom. There you go. Share it.
Okay. Let's go here. This goes here.
Okay, they got it.
Great. We did it, guys. Okay, so I'm just going to back up a little bit so you can see his chest x-ray. And after a prolonged vent wean with encephalopathy and diuresis, he came to hospital medicine. He had a prolonged course complicated by foot drop, encephalopathy, and leukocytosis. His labs were remarkable for lymphopenia, an IL-6 trend, which I'm hoping Dr. Stockstill can explain more to you. Leukocytosis that has gradually risen throughout his course here, and a mild AKI that resolved after his initial resuscitation. This is his most recent chest x-ray. He has been extubated on this film. So to summarize, this is the mechanics of a normal COVID case. He is now hospital day 20 and counting. He spent 10 days on the vent, and he was one of our first patients. He's still here, and we're still learning from him. The next one is a gentleman who presented with weakness from his assisted living facility and was known to be an AFib with atrial rapid ventricular response. Very common medical admission. We see hundreds of these every year. He was too unsteady to discharge safely, and this is an abrupt change. So he was admitted to our service after discussing with the emergency department that we all felt like his risk for COVID was low. He had no documented exposures, but EMS did give a verbal report of fever. We had no documentation of fever, however. On exam, he was tachycardic with RVR. He had a borderline SpO2. His platelets were mildly low. His AST was mildly And his chest x-ray had these multifocal opacities, which were bilateral. Because he had no respiratory symptoms, no GI symptoms, radiology said probably a good idea to get a CT of his chest, which we did and revealed these findings. The radiologist then recommended COVID testing. He was started on ceftriaxone and azithro, and I just want to pause here and ask the question, can we actually diagnose COVID with a CT chest? Well, it all depends on how common COVID is in your area. So at this point, we're assuming some kind of community spread, and in Wuhan, where this study was done, about 30% of the people they tested who got both a CT and a PCR on admission were diagnosed by the CT and not by the test. His course progressed. He ultimately went on hydroxychloroquine and ended up in the ICU intubated with a new fever. He was placed on pressors, and at this time he is still intubated. He is weaning the vent, but there are ongoing goals of care discussions with his family as to what to do after he is extubated. So the lessons learned from this case are that not everybody is going to present with fever and respiratory symptoms, especially early in their case. There are subtle clues that we can see on labs that are neither specific nor sensitive, but can be there. Respiratory failure can progress very quickly, and subtle findings on imaging, or not so subtle in this case, can be helpful. And then the last case we're going to talk about is a gentleman who was a known COVID positive patient who was out in the community for a week, after which he developed progressive nausea and vomiting. He had all the typical metabolic syndrome risk factors that we identify with these patients. He had sepsis on arrival to the ED, and he also had tenderness in his left upper quadrant. His chest x-ray showed predominantly a left-sided interstitial process. He had elevated inflammatory markers, that mild thrombocytopenia we're used to seeing at this point with these patients, and lymphopenia and leukopenia. He received a very similar course to the prior two patients, ceftriaxone, azithromycin, hydroxychloroquine. I do want to point out that if people are starting hydroxychloroquine, we should be transitioning them off azithromycin for QT precautions. And this man skated by. He did okay. He's on 1 liter oxygen as of yesterday, and 2 days ago, and he weaned off oxygen yesterday. So this is a gentleman who was not all that sick, but presented in an atypical way. So the lessons from this case are that GI symptoms can predominate. Quiet hypoxia is a subtle sign. Again, those lab abnormalities that we're starting to notice, and the lung findings don't have to be bilateral. So this is a very tricky situation. We have no idea what the illness script is if the patients fall off script. This is a study from pulmonary patients in a pulmonary hospital in Wuhan, and we think this is the story that they all go through, but the thing to know is that these patients are all in a pulmonary hospital, so there's going to be sampling bias. So this is kind of the initial data that everybody's quoting from Wuhan, but you know, whatever you put into the model, you're going to get out of the model. Again, this data is from Wuhan. It's that same group. Most of them were male. A surprising amount were not smokers, actually. So I think there's a misconception that smoking was driving a lot of the Chinese data. In this particular sample, it was not. And they all, not all, but a significant proportion demonstrated that metabolic syndrome. But also a significant proportion presented with soft or subtle non-respiratory symptoms: myalgias, fatigue, diarrhea, nausea, vomiting. And a lot of them, especially those who were non-survivors, you can't really see it because of the screen right now, but the non-survivors presented with a significant degree of lymphopenia. In our patients right now, we're getting a lot of biomarkers, and we're using them primarily to help with prognostication. In this set of graphs, non-survivors are in red, and you can see the higher the inflammatory marker, the more likely you were to be a non-survivor. So just to review our scripts, the scripted presentation is a lung, marrow, liver presentation, and this is how Norm presented. And then there's a much more diverse group of people who present with something from cytokine drizzle to cytokine storm, and the presentations are manifold. So the danger in this situation is that really important symptoms like dyspnea can get categorized 100% as COVID, when you can think of at least 5 things that'll kill a person with dyspnea. And then the other side of the coin is that there are very common problems that can be COVID that we are often writing off as not being COVID. So this all comes down to what is the pretest probability of the patient. If the patient's on script, the pretest probability is high, and if they're off script, it's a variable pretest probability of which we have no idea. So this is when the clinical acumen has to be high. And then one last comment on the test. So we have all the same problems that Wuhan had at the start of this. They had a high false negative rate, they had unavailability of tests, and when you look at this pyramid down in the corner, most of the people being tested were the ones with true illness. So we don't know how people at home were feeling when they were having their COVID. All we know is what it was like to have COVID if you had a confirmed positive test. So we're literally looking through a keyhole. And with that, I'm gonna hand it over to Bob.
So whenever sensitivity and specificity goes up on the screen, everybody's eyes glaze over, including me, including when I'm talking about it. But whenever a new test comes out, we really have to have a good sense of the sensitivity and specificity to figure out how to interpret the results that we get. So just really, really briefly on background, you guys remember that tests with a high specificity are helpful for ruling in a diagnosis. If it's very specific, you can help rule it in. It helps rule it in. Remember, SPIN, specific helps rule it in. Tests with a high sensitivity help rule out a diagnosis, so SNOUT. So to help rule out a diagnosis. But these are population-based numbers. These are really useful for comparing one test to another. They're actually not that useful for figuring out what's happening with a patient right in front of you. Because as Catherine mentioned, it's really the pretest probability, the clinical probability of disease that you have for that disease when you do that test that really affects test interpretation more than anything else at all. So clinical probability, this is half of diagnostic medicine, just trying to sort out what you think they have on the basis of what you know to date, history, physical labs, imaging. And you refine that clinical probability multiple times as you're seeing somebody. So these are 3 of the major determinants of clinical probability: the baseline prevalence of disease, the likelihood of other diagnoses, and the symptoms, how well it fits. So the baseline prevalence of disease obviously is here in our community now, but the baseline prevalence is much higher in New York City probably than it is right now. So there, somebody walking into the emergency room there has a higher clinical probability of disease just on the basis of where they are. Probably one of the most important ones is the likelihood of other diagnoses. If you have something that looks really, really likely, the corollary effect is that the likelihood of COVID goes down. So if you have somebody who has dyspnea, orthopnea, PND, and S3 RALS, JVD, lower extremity edema, and has a known EF of 15%, the likelihood of CHF goes way up, and the likelihood of COVID goes down, driving down your clinical probability of that. And the last one is just how representative the symptoms that your patient is having are for that disease. How strong is that strength of association? So for dyspnea, obviously with COVID, it's pretty high. For diarrhea and some of the other GI complaints, maybe less so. And what we have to do as clinicians is put all these things together and come up with a clinical probability of disease, because we cannot interpret test results unless we have this baseline clinical probability of disease. So, again, how good the test is depends on the sensitivity and specificity, but we don't use those numbers in applying it to an individual patient. What we need to do is take those characteristics and apply it to the patient that we have in front of us with their clinical probability of disease. So I'm going to walk through 3 different slides now and talk about the effect of the clinical probability of disease based on the the sensitivity and specificity of the test. And these are really the money slides. This is probably the least optimistic, but probably the most realistic version of what the test looks like. You see the assumption across the top is that the pharyngeal swab has a sensitivity of 70% and a specificity of 98%. So pretty good at ruling it in, not that great about ruling it out, all right? And so if you take your clinical probability of disease and you just put them into three strata, 25%, 50%, and 75%, you can do the statistical modeling and come up with what your post-test probability of disease is. Just what your clinical probability and that test result, this is the likelihood that they have COVID. And you can see the numbers are kind of sobering. If you look over at the positive test result side, you can see you're over 90% for each of those. That if you have a positive test, even if your clinical probability is 25%, you're going to believe it and you're going to say they have COVID. Nobody's going to say, well, there's an 8% chance it's not COVID, forget about it, all right? The much more difficult thing is even with the clinical probability of 75% and you have a negative test, you still have a 50% chance that that patient has COVID because your clinical probability was so high. All right? And even if you only had a 25% chance, yeah, probably not, but maybe, you're still left with a 10% chance that they have COVID. And again, this is with a test with 70% and 98% things. This gets to the threshold to treat. What's our threshold or threshold to test? What's the likelihood of disease below which we blow off that diagnosis? We say, I don't need to worry about that anymore. That varies obviously by the disease, and I don't think we know what the threshold to test is for COVID. Are we okay with 9%? Seems a little high if somebody has a 10% chance of COVID and we're not isolating them. So if you get a little more optimistic and you say the sensitivity of the test is 80% and the specificity is 98%, you still see, even with a negative test there, you still have basically a 1 in 3 chance they have COVID if you said they have a high clinical probability of disease. You're getting better at ruling it out with a 25% probability. And then if we're where I don't think anybody thinks we are, where we have a test with a sensitivity of 90% and a specificity of 98%, yeah, pretty good at ruling it out if we have a low clinical probability of disease. But if you walk into the room and say, I think this patient has a high clinical probability of disease based on our prevalence, based on their symptoms, and based on I can't really think of anything else this could be, there's still at least a 25% chance this patient has COVID. All right? So these numbers are pretty sobering. Nobody's really sure the exact sensitivity, and if there are issues with sensitivity, how much of it is pre-analytic? In other words, did we stick the thing far enough back? There's a great editorial in the New York Times from yesterday that Harlan Krumholtz wrote. That basically says if they don't feel like you're tickling the back of the eyeballs, they didn't do it right. All right. So the bottom line with all of this is that a high clinical probability of disease and a negative test doesn't even come close to ruling out COVID. This is exactly what we do all the time with PE and D-dimer. If somebody has a high clinical probability of disease, we don't even order the D-dimer because we know it's not going to get it low enough so we stop thinking about that diagnosis. Repeat testing is probably a good idea in most of these patients who we think have even a possibility of having COVID because we need to drive that clinical probability down. And hopefully over the 36 or 48 hours that you wait to do the second test, something comes up in terms of the likelihood. So you know what, this actually is heart failure. This really is community-acquired pneumonia, or the likelihood of COVID goes up. And then, as I said, what's the appropriate threshold to test? With all of these alternate types of presentations that Catherine brought up, who should we be testing? When, if we say there's a 10% chance of COVID, should we be testing folks for COVID? So if you ever want to model this yourself, you can just email me for this thing. There's some great online calculators where you can put in clinical probability, the test characteristics, and actually get your post-test probability.
Can you tell people to mute their?
Yeah, and if people on the phone or on the computer could mute their microphones, would be great.
So I'm hoping Joel Worth is still in the audience. Joel, if you're in the audience, can you unmute yourself and let us know?
Yes, I'm here, Catherine.
Okay, so I can advance your slides for you if you want to talk a bit.
Sure. So next slide.
I switched.
So we've had a little bit of experience. Can people hear me okay?
Yep.
Okay. So we've had a little bit of experience, as you can see here, with case numbers building at the medical center. We're at about 40 inpatients, and we're running about 2 to 1 between the inpatient hospitalist service and the critical care service. So we're at about a dozen ICU patients today. As noted, we've extubated 3 people so far. But these are long intubations, both in the literature and our limited experience here too. And we've had about 13 hospital discharges so far. So next slide. The pathology for the COVID cases is basically diffuse alveolar damage, which is what we saw in SARS and MERS. So this is really pretty stereotypical ARDS. And so we'll talk about management, but from our standpoint, this is bread and butter ARDS management. Next slide. There's viral inclusions in alveolar type 2 cells, and there's also evidence of viral impact. I won't say direct infection, but impact on myocardium and other tissues as well. So next slide. This is the diagnostic criteria used in Wuhan for COVID-19, and as Bob was alluding to, the testing, the negative tests don't necessarily rule out cases. I had gotten a COVID handbook from one of the university hospitals in China, and their approach was to actually do daily PCR testing, and anybody admitted, and only after 3 negative PCRs and a negative IgM would the patient be deemed COVID negative. They obviously had a lot more access to testing than we do. So I think we're still trying to sort out who we test and who we retest, but we are retesting certain ICU cases where we have a high clinical index of suspicion, even in the face of negative, single tests, or even sometimes 2 negative tests. So next slide. This also shows that we're doing typically nasal swabs, and that sputum samples have a higher yield for the PCR specimens. I think currently, as it stood early in the week, Nordex was not validated to run sputum samples. They were only validated for nasal swabs. So we did have an ICU case where we had run 2 negative nasal swabs. They were intubated. We did send respiratory secretions through the ET tube, both to the state as well as to Nordex, to try to get a 3rd sample. So, but just to be aware that there's differences between the different sampling sites. Next slide. In terms of transmission, just as I think as people know, the transmission can be from relatively asymptomatic people, and certain number of cases, and people are aware of the PPE rules that we're following now. So it's PAPR in the ICUs and for aerosolizing procedures like intubation, and then N95 masks for some of the new units coming on where there's not aerosolizing procedures being performed. Next slide. This was the spectrum of disease seen in the Chinese group. So 81% mild or asymptomatic, about 14% hospitalized, 5% critically ill. These numbers are actually pretty similar to what we're seeing here in Maine if you look at the number of tests sent, the number of positive cases, and the number of people in the hospital. So next slide. And then this is just the risk factors for mortality in patients with COVID-19 out of Wuhan. So this is 2 hospitals in Wuhan with 191 patients. This was published in The Lancet. I think Catherine had a slide from this article. So 54 patients out of the 191 died. And the ones that died, a lot of them had hypertension, diabetes, coronary diseases, comorbidities. And the odds of dying went up with age, with SOFA score, and with high D dimers, high inflammatory markers. And the median duration of viral shedding, telling me, was 20 days in the survivors by serial PCR. So next slide. This just looks at some of the clinical features. and I think Catherine went through this, so I won't belabor it, but lymphopenia, high CRPs, high D-dimers, high troponin, LDH. So these are some of the findings. We're seeing not that much acute kidney injury. I think 1 out of the 12 so far in the ICU has had an AKI of significance. There's some minor AKIs, but not to the same extent. There is fairly stereotypical that once these patients get intubated, they're all somewhat septic, so almost all of them end up on low-dose suppressors, almost to a patient, and whether that's because of just viral sepsis or whether it's somehow that the virus is entry to cells is being mediated through angiotensin receptor 2, angiotensin 2 receptor is mediated, and that somehow is influencing blood pressure. It's not really clear, but it's fairly, almost ubiquitous within these patients that we intubate them, and they will end up on a low tidal volume lung protective ventilation strategy, and they almost all end up on low-dose suppressor for the first couple of days. So next slide. I think Catherine showed this slide just with the prolonged course and where ventilation falls in. One of the things we're also seeing is that as patients transition up in terms of oxygen requirement and end up on high flow, they can worsen fairly quickly. So we have a understanding with our colleagues at the ABU where they're managing patients on high flow, non-intubated, to be in contact with us and communicate about anyone who's rapidly worsening or needs high flow above 50%. There's a protocol we have from Mount Sinai New York where they're intubating all patients on 60% or higher high flow. I think we want to evaluate each patient case by case, but just be aware that these patients seemingly can go down pretty quickly. We've seen a lot of patients deteriorate in 12 hours, for example. Next slide. These are just some of the laboratory tests as were mentioned earlier. So, the D-dimer, lymphopenia, IL-6 levels, ferritin levels, troponin levels. And I think the last one is LDH.
Yeah.
So, okay. So next slide. Typical CT findings. This is from a Chinese case, just showing, diffuse ground glass, typical posterior pattern that we would see in ARDS from other causes. Next slide. So our ICU management is really fairly typical management of ARDS. So early intubation, and we would say if people are having a rapidly progressive course, ending up on high flow nasal cannula, that we consider getting those patients to the ICU for evaluation for endotracheal intubation. In ARDS studies in general, non-invasive ventilation is associated with worse outcomes. So for most cases, non-invasive is probably not something we're going to be employing. Lung protective ventilation, which is the standard of care for ARDS, so low tidal volume strategies, maintaining low plateau airway pressures, and then high PEEP versus low PEEP. I think there are some nuances to that depending on the patient's radiographic patterns, but most of these patients end up on high PEEP protocol. And what we're seeing is we'll start on 100% and PEEP of 15, and then usually within the first 12 hours, their FiO2's coming down nicely, but they remain on high PEEP with a very slow weaning on the PEEP. Prone ventilation we're using for refractory cases, which is, again, evidence-based. This is a picture of someone with prone ventilation, and we've proned, I think, 2 or 3 people now in the ICU, and then conservative fluid management from the FACT study. And then doesn't show up well on the slide, but there was a small number of cases that went on to ECMO in China and in Italy from talking to colleagues, as well as in Seattle. So that's something that we can employ here. But again, it was probably under 5% of cases went on to ECMO. Next slide. So this is just a list of some of the antivirals. And I think, I don't know if Patty is going to be speaking next about sort of the antiviral possibilities. So I won't belabor this, but the slide should be available to people. This comes from the Lancet. Next slide. Corticosteroids are controversial. All these patients that we've seen are fairly lymphopenic, and so reasons to consider not giving corticosteroids. In China, they were trying to limit corticosteroid dosing, so to keep it low to moderate dosage in short term. So next slide. And these slides are from this physician, Bin Cao, in Wuhan, and they've been a good source of information. And as you guys know, the literature is slowly building about some observational studies, and we're hoping to see more clinical trials performed. But so far, much of the literature around this has been observational. So that's all I have. So any questions?
If you do have questions, please unmute your microphone so we can hear you.
This
Okay.
is Mike Roy. I actually had a question about our testing. So I've been in a meeting where Augie Valenti quoted sensitivity for the Nordex test of 99.6%. And I don't remember the specificity, but it was in the 90s. Kathleen Fairfield had a conversation with him and got the same numbers from him. So are you all working with that assumption or not?
So Mike, I've heard Augie give those numbers too, and I have to think that they're probably not accurate, both from the standpoint of the obtaining of the specimens, but also from the data that comes out of China and Italy in terms of the sensitivity and specificity numbers not being that high.
So we're pretty much in the dark as to what our sensitivity is.
Yeah, I mean, I think actually the most robust studies that I've seen come out of China where they're testing people daily. And their protocol there, but one of the reasons they built those 1,000-bed hospitals was if you had fever, you were supposed to show up and you would be admitted until you were ruled out for COVID. So even the mildly sick people would get tested. And some of the data coming out of places that are testing intensely, like South Korea and Germany, you know, that's where the number of asymptomatic carriers are being defined. It was just a news article today, I think, about a traveler who came back and was with a group, and a third of the group was positive but asymptomatic. So I think that the amount of spread that we're seeing, as well as the test characteristics, are not totally well defined.
Yeah, I've been seeing 30% false negatives online in what I've been reading. So I think that's more reality.
I do too. So just have a high index of suspicion and consider retesting for cases. The radiographs are fairly stereotypical too. I know sometimes they're asymmetric, but this reticular nodular pattern that we're seeing doesn't look like a lot of other typical, well, I would say atypical pneumonias, you know, or other typical X-ray patterns. So it's different than we're seeing with, say, varicella pneumonia or flu pneumonia. It is somewhat, you know, when we look at the films in the ICU one after the next, they're all fairly similar, actually.
Hi, this is Christine Hunt. I wanted to chime in here on this as well. I think that this is an excellent point to reinforce. I've heard those same numbers about the sensitivity of our testing, and it is obviously at odds with what has been published so far in the literature. I also saw an interesting statistic recently of one of the earlier cruise ships where everybody on the ship was tested, and of the people, there was like 697 people who tested positive. 47% of them remained asymptomatic in the 4-week follow-up that they had. So I'm sort of with Joel on this in terms of retesting patients who have ongoing symptoms and not putting all my eggs in a single negative test.
And if people recall, in China, they were reporting their numbers rise in Wuhan, and then one day they had this huge spike in their numbers because they changed the case definition to include chest imaging. And so I think they were also recognizing that they were probably had a false negative problem with the testing.
Patty Stockstill, are you?
Hey, Joel. Oh, sorry.
Go for it.
This is Emily Zurkin from the hospital service. There's been some suggestion that we should be proning patients like in the ICU who are having increasing oxygen requirements. Can you talk about if you think that would be a good idea, and then just like technically how you prone the patients, how long they should be, like how the rotation should go?
Yeah, that's a great question, Emily. So there is this anecdotal evidence and some discussions among the pulmonary critical care docs around the world about sort of the non-intubated patients being proned. And I think it's simply you have them sleep on their belly if they're able to sleep on their belly. And so nobody has exact guidance about whether, how to do that or how to go about that. But I think I would certainly try it. It's not harmful. And the pronation literature for ARDS says to do it for 17 hours or thereabouts. So we do these very prolonged initial proning and then flip the patient back over supine and then reassess whether they need a second episode or not. So I think you could kind of follow those guidelines of at least, if they can at least sleep or maybe spend 12 hours on their belly, as long as they're not in respiratory distress. I think if someone's tachypnic and they're struggling, I wouldn't necessarily try it in those patients. But if you have patients who are, are sort of admitted and, it might be worthwhile trying it to see if it can improve their oxygen requirement. So anyone else have thoughts about that?
Emily, where I've been able to, I'm in the ABU this week, where I've been able to, I've suggested patients lay on their bellies as much as they can, but I'm finding most of them are in so much distress at that point, unless they're intubated and paralyzed, it's not really possible.
Yeah, I think it might be more a strategy for people on the floor who aren't too distressed.
And Joel, Lisa Almeida here. Can you explain how does that work? Why is it the prone position help?
Yeah, Catherine, can you back up to the CT slide?
Sure.
So right here, if you look, these are supine CTs, and most of the disease is posterior. And this is a fairly typical finding from ARDS of almost any cause. And why that is not totally clear. It may be because there's more inflammation posteriorly where the blood flow is by gravity. And so if you just flip people over and put their anterior side down, you get better ventilation perfusion matching. And it seems to aid recovery. It might also improve airway clearance. That is the dependent portions of the lung that might have inflammatory material and mucus in them. Patient can then raise and clear that out a little better by using gravity.
Thank you.
Christine or any of our ER colleagues, I'm curious to hear what your experience with patient flow has been in the last couple of weeks.
Well, we've seen a continuous, this is Christine again, sorry. We've seen a continuous increase in the number of patients who are presenting, and really I would say at this point, our overall volume is down by about 50% from pre-COVID times, but I think a substantial percentage of our volume now is COVID, either PUIs or concerns, so probably 40 to 50% of our volume right now is specifically related to COVID. So that's left us, we initially, ironically, Friday the 13th was kind of the worst day for us in all of this so far, and it's when we had to rapidly shift our strategy kind of on the fly during that day. We were able to convert our entire Bayside to a COVID unit, which we're lovingly calling the Castle now because it's all enclosed. And it's been entirely converted to a negative pressure space. We're working on converting our CDU as well, which should be done next week, hopefully, to a negative pressure space, as well as some area in the waiting room currently that is a little bit more amenable to a rapid conversion. So based on what we're seeing from other emergency departments around the country, I think we could expect, if we do have the surge of patients that we're expecting to see, that anywhere from 2/3 to 3/4 of our emergency departments will be converted to COVID space and care of patients who are under investigation.
Yeah.
Can we, if we go back to the
Katie,
testing,
can I ask an unrelated question?
Hang on just 1 minute. Dr. Meyer has a question about testing.
so if we go back to the testing question again, we mentioned a few times the role of CT as an adjunctive tool in making diagnosis of COVID. So how are we doing with that here in Maine Med? Are we using CT on our COVID services? Can we use it more effectively? How can that help us? Any thoughts on that?
The protocol for radiology right now is it requires, a 30-minute clean